Welcome to another EduMed video, and in this final video on the Surviving Sepsis COVID-19 guidelines, we'll be going through the COVID-specific treatments and the recommendations that have been made for each of the different specific treatments that have been suggested for COVID-19. This is based on the Surviving Sepsis campaign guidelines, which were published online recently. It is worth pointing out that this is from a panel of 36 experts from 12 different countries. They reviewed quite a lot of the data. They did themselves a number of meta-analyses and collated quite a lot of data, so it's a really useful document to read through, and I'll have a link to the document in the description below. As you're probably familiar with most guidelines, what they do is they rank the strength of the suggestions for each of the specific guidelines as either a weak recommendation or as a strong recommendation or a best practice. As you'll probably see as we go through, in terms of the COVID-specific treatments, there's weak recommendations for all of them, or either for or against its use, and essentially there's been no proven treatment for COVID-19, so all of them are a weak recommendation against the use of them until more data is available. One of the things that we are seeing with COVID-19 is this so-called cytokine storm. We're seeing a massive increase in CRP, IL-6 and other inflammatory mediators. They've developed this hyperinflammatory state, which then they suggest may be going on to causing fulminant multi-organ failure. And certainly the elevated cytokines are measurable. Interestingly, there's been some suggestions of there being an overlap with a Haemophagocytic lymphohistiocytosis type picture, and also with a macrophage activation syndrome. Early on, there were suggestions of using a modified H-score looking for HLH. And certainly we have seen that these patients get high hypertriglyceridemia, high ferritins, high D-dimers. The relevance and significance of this is yet to be fully elucidated in the literature. One of the questions when dealing with a hyperinflammatory state is whether we should be giving steroids to dampen down that inflammatory response. There's a couple of aspects to the recommendations. What they've suggested is that in mechanically ventilated patients with respiratory failure without ARDS, and that's the classical Berlin definition of ARDS, looking at PF ratios, and what they've suggested is not using routine corticosteroids. This is based on weak low quality evidence, so it's a weak recommendation, but may be reasonable. And certainly the early management of these patients was with lots of steroids, and as time has gone on, more and more people have stopped using steroids as a starting point for all diseases. And certainly there are disadvantages to using steroids, which we'll go through later. Interestingly, what they've suggested is that in patients who have mechanical ventilation with COVID-19 and ARDS, they are suggesting the use of corticosteroids. Again, this is weak recommendation based on low quality evidence. Now, this is mainly based on some evidence on the use of steroids in patients with ARDS having better outcomes, and we'll go through that in later slides. However, it's weak recommendation. I think it is worth taking on a patient-by-patient basis. So in terms of looking at high-dose steroids, specifically in the COVID-19 population, there is a case report of 26 patients from China where they gave 1 to 2 milligram per kilogram per day of methylprednisolone for 5 to 7 days. And what they did find was that there was a reduction in the amount of supplemental oxygen required, and that it improved radiographic findings. Of note, This was mainly in patients who were not admitted to intensive care. You can see that the amount of time that the patients had supplemental oxygen was lower by a few days. Now, this is a single centre study. It's looking at a very small number of patients, and the cohort isn't a complete intensive care cohort. So it's very difficult to extrapolate this to the rest of the COVID-19 group. So we really do need more studies. It is worth considering the non-COVID data. And there was a systematic review looking at community-acquired pneumonias in non-ICU patients. And this was a mixture of bacterial and viral pneumonias. And what they did find was that by using steroids, they did reduce the need for invasive mechanical ventilation quite significantly. And you can see here the confidence interval doesn't include 1, and therefore there was a reduction in the need for invasive mechanical ventilation. It also reduced ARDS and dropped the mean duration of stay in hospital by about a day. But the question then comes with whether we should be using steroids in viral pneumonias, because essentially the way a viral pneumonia gets better is through the patient's own immune system developing either an acquired or using its innate immune system to try and destroy the virus and to clear it from the body. And so by using immunosuppressants, although it might reduce the cytokine release and the secondary damage that can occur from hyperinflammation, it does, however, impair the ability for the virus to be cleared. And so this is an interesting meta-analysis that looked specifically at steroids in viral pneumonias. This was an observational group of studies. So there were mainly cohort studies, and it was a meta-analysis of these. So they were only really looking at those people who were getting steroids. And as a confounding factor, only really sick patients were getting steroids as a matter of standard practice. This looked at 15 studies with influenza and 10 with coronavirus. This is non-COVID, so these were all before 2019. And what they found was that there was an increase in mortality, and quite a significant one, the odds ratio of 2.76. Maybe a slight reduction in the coronavirus subgroup, so it might be that influenza acts differently to coronavirus, and the honest answer is we just don't know. You can see here the odds ratio of the confidence intervals passes 1, and so it's difficult to say whether there's a benefit or if there's a risk to using steroids. But certainly there was this signal towards it being more risky to give steroids in viral pneumonias. And then it's worth looking at the ARDS data, and this is really why the recommendations from this group suggest using high-dose steroids in patients with ARDS who are mechanically ventilated with COVID-19. It's based on 7 RCTs with 851 patients, and what they showed was they reduced mortality and they reduced duration of invasive mechanical ventilation. But it's really important to note that this was not specifically for viral ARDS. This was a combination of virus with superadded bacterial infections, or those patients with bacterial infections, or, as we often find with ARDS, we don't find a causative organism at all. Really interestingly, there was the INTEREST trial that looked at the use of steroids with recombinant interferon beta 1b. And what that showed was that there was no change in mortality, but the subgroup who did have steroids had an increase in mortality. So overall, it's not very clear whether steroids are going to be beneficial or not for patients. And there are certainly side effects to the use of steroids. There's been a lot of papers suggesting that there's increased viral shedding, and of course the other risks such as muscle wasting, secondary bacterial infections, delirium, to name but a few. So steroids are not without their risks, and certainly with viral infections it's not clear whether it's going to be a good thing or a bad thing. And we're extrapolating data from non-COVID groups, so really we're not entirely sure whether steroids are a good thing or not. So although the guidelines suggest using steroids for patients with ARDS and COVID. Actually, that needs to be taken with a little bit of caution and on a patient-by-patient basis. One of the questions is whether to give empiric antimicrobials, so antibacterials, to patients with COVID. And the guidelines themselves take a practical standpoint with this. They suggest using empiric antimicrobials over not using it. And the rationale for that is it can be quite difficult in the early stages to know whether you're dealing with a viral or a bacterial pneumonia. We certainly know from a lot of the Surviving Sepsis Guidelines and other research that the delay in antibiotics can significantly increase mortality and morbidity in patients. So by using empiric broad-spectrum antibiotics to begin with, and then stopping or narrowing its scope or range at a later date is probably a reasonable and safe thing to do. And certainly in patients with critically unwell disease with evidence of multifocal consolidation on x-rays, it would be a brave clinician to not use antibiotics to begin with at least. Anecdotally, the use of procalcitonin seems to be quite useful in trying to see which patients have a superadded bacterial infection on top of their COVID viral infection, and using that to start and to stop antibiotics might be useful, but that needs further research to be able to validate that. So the guidelines themselves are based on other viral pneumonias, but we do have some data for COVID. The Wuhan data suggests that 53% of patients got IV antibiotics, but over 90% admitted to intensive care got IV antibiotics. I think that's entirely reasonable and probably reflects similar to what we're seeing now. It's also important to note that not many patients had appropriate respiratory samples because Wuhan was just inundated with patients when it first started, and as such it was very difficult for them to send off full septic screens. So some of these patients may have had underlying bacterial infections as superadded infection to their COVID disease, but because they were just inundated, unable to send appropriate samples, there's not a full data set to be able to look at these patients in detail. Certainly in the MERS data, we found that about 18% of patients had superadded bacterial infections with Staph aureus and influenza pneumonia. And interestingly, 5% had a viral superadded infection. A similar sort of thing was found with influenza. And so based on this data, it's fairly clear that about 1 in 5 patients are getting superadded bacterial infections, certainly if they're intubated and ventilated. And if that is the case, using empiric antibiotics to at least to begin with, and then monitoring thereafter for the inevitable ventilator-associated pneumonias is probably reasonable. Interestingly, the guidelines actually look into whether to use antipyretics and temperature control. And what they've suggested is the use of paracetamol for temperature. Now, there is a question as to whether we should bother using temperature control at all for patients. And there have been a number of studies, in fact, in intensive care looking at the management of temperature and whether getting rid of a fever is a good or a bad thing. And essentially, managing temperature doesn't seem to reduce the risk of death or intensive care length of stay. They do suggest the use of paracetamol, and I think that's probably more for comfort and for trying to manage the hemodynamics of patients with tachycardias, lactate production, increase in metabolic demand. And I think that's probably not unreasonable. However, there are some units, certainly based on a number of recent trials, that have stopped using regular paracetamol altogether in intensive care and just use it as a PRN drug. That will be up to local policy. It is important to just note that non-steroidals, there have been questions about its safety in COVID and also just in critical care patients in general with its risks for nephrotoxicity. certainly I don't use non-steroidals in intensive care very often, and paracetamol has got a much higher safety profile than many of the non-steroidals, so it's probably one to avoid. There's been a lot of talk about, with this hyperinflammatory state, whether we should use intravenous immunoglobulins. And the guidelines suggest against the routine use of it. There have been some case reports, but the thing is that there are no titers of neutralizing antibodies, so we don't know whether it'll work or not because there's no antibodies there to neutralize. Certainly looking at the influenza dataset, there was no evidence of benefit. And there are risks with IVIG. These are essentially the risks that you get with any transfusion. So you can get anaphylaxis, aseptic meningitis, renal failure. There's a thrombotic tendency with giving any transfusions of stuff, especially IVIG. And when we look at the COVID dataset, they're already at such a high risk of thrombosis. Some patients develop hemolysis, and of course transfusion-related acute lung injury can occur with any infused donor products, of which IVIG is one. There's been a lot of interest in the use of convalescent plasma, the theory being that if we can take the plasma from people who've already had COVID infections, develop the antibodies, and then give those antibodies to people who are fighting the disease, it might help to shorten the duration of disease and to clear the virus quicker. Now, this at the moment suggests against using convalescent plasma, and really the reason for that is because we don't have the data set yet. The theory, as I said, is passive immunity, very similar to how the breastfeeding mother will pass on passive immunity to their fetus in the same way by giving blood plasma from someone who's already had the infection, developed the antibodies. We may be able to reduce the risk of getting severe disease or even preventing the viral disease in the first place. It has been used for other viruses, so SARS, avian influenza, and influenza A, amongst others. It did reduce the mortality in some of the randomized controlled trials, but it was used in China, but it had unclear benefit, and it was in small numbers in single centres. So there's a big UK study that's being recruited at the moment to look at the use of convalescent plasma, but those results won't be out for a while yet. So as it stands, convalescent plasma is not indicated in this disease. In MERS, there's a suggestion that it may have worked, but there was only a very small pool of donors who actually developed a high enough antibody titer to be able to donate the plasma. And one of the problems with convalescent plasma is not every patient has a big immunogenic response with the production of adequate numbers of antibodies that can then be transfused to other people. In Ebola, again, they didn't find that convalescent plasma had any benefit, but interestingly, they just gave this convalescent plasma from donors with unknown levels of the neutralizing antibody. So it might be that those patients didn't have a high enough titer of the antibody to be able to give an appropriate antibody transfusion to the recipient. The influenza trial actually stopped early due to futility. So overall, in other diseases as well, and other viral diseases specifically, it doesn't seem to be that effective, and that might be partly relating to finding the right donors. There's been a lot of talk about the use of Lopinavir, Ritonavir, and early protocols suggested using this as a starting drug. But actually, as the data's come out, they've suggested against the use of routine Lopinavir, Ritonavir. So Lopinavir and Ritonavir were used mainly for HIV, And the theory was to try and reduce viral replication. But with all antiviral medications, they've not been proven to reduce viral replication. There are many other ones aside from Lopinavir and Ritonavir that are being looked at, and some of them are written here. But all of these are under testing, either in combination or as standalone treatments, and as yet we just don't have the data to be able to recommend or not any of these treatments. So Lopinavir Ritonavir as a combination drug is used as a protease inhibitor in HIV. It has been used in other viruses, and in SARS they looked at 41 patients where they gave the Lopinavir with the Ritonavir and high-dose Ribavarin with steroids as well. Interestingly, what it found was that there was a lower mortality and ARDS rate compared to controls. Now, bear in mind this is a very small group of patients. In MERS, what they found was that it inhibited the replication of the virus in vitro, so not in the patient. And there are trials in MERS looking at the combination of Lopinavir Ritonavir with interferon beta. In the COVID-19 group, China actually published 199 hospitalized patients, of which 44 died, and looked at the use of Lopinavir and Ritonavir in a randomized control trial. And what they found was effectively there was no change in 28-day mortality and no change in the time to improvement. However, what they did find was that there were more adverse events, and that's the main reason that people have suggested against the use of routine administration of Lopinavir Ritonavir. There are a couple of big trials that are awaited who are developing a trial, and prior to all this, there was the REMAP-CAP trial that was looking at this as well, which will now hopefully use some of the COVID data as well. One of the drugs that there was a lot of excitement about initially was Remdesivir. Remdesivir is a prodrug of an adenosine analog. And what it does is it basically interrupts RNA replication. The reason that viruses are so damaging is that what they do is they incorporate themselves into the cell, and then they replicate their genetic material and then effectively make the cell toxic, stops its normal use and production of things, and therefore kills it. And by having these analogues, what they do is they prematurely stop the viral replication of that genetic material. It is a promising drug, but we're awaiting a number of trials. So there's the WHO trial that we're awaiting, and there are multiple American studies that are awaited as well. In vitro, it has been shown to inhibit coronavirus, so the COVID-19 SARS-CoV-2, MERS and SARS. So it has got some promise, but we are awaiting proper clinical trials. Now, there is insufficient evidence at the moment to actually give any kind of indication of whether recombinant interferons should be used either alone or in combination with the antivirals, and there's a number of trials, as I mentioned, that are looking into this. Recombinant interferon is often used in combination with Ribavarin, and it was used in both MERS and SARS. There are multiple preparations of the recombinant interferon, so it is important when looking at these trials to look at the actual interferon that was used. In a MERS cohort study, they found that there was no change in mortality. As it stands, there are no studies published in COVID-19 SARS-CoV-2, but the in vitro studies do look quite promising, and again we're waiting for a big WHO study which will look into this. A couple of drugs that were given a lot of prominence and a lot of press time was chloroquine and hydroxychloroquine, but essentially what they found is there's insufficient evidence to issue recommendations, and actually there have been a few small trials that are starting to be published that suggest no benefit in the use of chloroquine, hydroxychloroquine, in these patients. Now, some people argue that maybe they lacked the addition of things like zinc or other co-drugs. Honestly, though, it's too early to tell whether it's helpful or not, but the early signals are that it doesn't seem to have a huge benefit. Hydroxychloroquine is one of the metabolites of chloroquine. In vitro, there certainly is some anti-SARS-CoV-2 activity. It's a very good anti-malarial, and it's some of its actions are through the transposition of ionophores. Interestingly, it has been looked at as an antiviral for other viruses, and so it's been looked in quite a lot of things such as dengue, chikungunya, and influenza. And it really hasn't shown any benefit in any of these diseases. And in fact, in chikungunya, when they did primate studies, they actually showed a worse outcome. Recent studies suggested no benefit, but there might even be a slight increase in morbidity, and especially cardiovascular morbidity, with the prolongation of the QT interval in combination with some of the other intensive care drugs that we use that could potentially give rise to cardiac arrhythmias and other problems. As I said, there is a question of whether hydroxychloroquine or chloroquine should be co-administered with other drugs, and certainly all of that needs to be looked into in a lot more detail. Tocilizumab is another drug there's been a lot of interest in. It's a humanized immunoglobulin that blocks IL-6, and it really blocks it binding to its receptor. As we mentioned before, one of the major worries with coronavirus and COVID-19 disease is that hyperinflammatory state, and we think that a lot of the damage that happens to the body is due to that hyperinflammatory state caused by the virus. And so by blocking IL-6, you knock out a huge amount of the inflammatory process that occurs within the body. It's got a good evidence base for rheumatoid arthritis and juvenile idiopathic arthritis. However, there isn't really any evidence for its use in COVID-19 yet. The theory is that you attenuate that cytokine release syndrome, and there are some trials that are ongoing at the moment, so hopefully we'll have an answer in the next coming months to maybe a year. It should, however, be noted that there are risks, and certainly in the rheumatoid arthritis group, they found that there was an increased risk of adverse events and especially infections. And so we do have to be careful. Of course, whenever you dampen down the inflammatory response, you're going to reduce the amount of destruction of pathogens such as virus and bacteria. So even though we might be reducing the inflammation, we may actually be propagating the virus. So again, before this can be properly recommended, we need to have the adequate data there, because there are risks involved with all of these treatments, and if there's no clear benefit, we do have to be cautious. There are a couple of other drugs that are being looked into as well, and Nafamostat, which is a serine protease inhibitor, certainly has shown some utility in MERS, mainly in vitro, and there are other antiprotozoal agents as well which have some antiviral effects in other viruses, but again hasn't been investigated in SARS-CoV-2 yet. So in summary, I think the important thing to note here is that there is no real specific treatments for COVID-19. There's lots of promising research that's being done, but the honest truth is that it's going to take months, if not years, for these results to actually come out and to change our practice. And it's important that we don't just dabble with things that haven't been proven, because every single drug that I've described here has got significant side effects. And if it doesn't provide any benefit for patients, then it may well give them the side effects and not give them any benefit at all. And one of the key things that we need to do is to do no harm. And actually, by focusing on getting the basics of intensive care right for patients, they're probably going to give much better results than any of these drugs as it stands. It is still early days. Methylprednisolone may be helpful in patients with established ARDS with multifocal consolidation on their chest x-ray, and people are tending towards using it. Certainly in my practice, once they've established significant patchy consolidation and they're otherwise cardiovascularly stable, I do have a low threshold for starting high-dose steroid. There are lots of RCTs that are going to come out, but like I say, and I really can't emphasize this enough, do the basics well, and you'll probably have much more of an effect on morbidity and mortality than these drugs as it stands at the moment. If you found this useful, please like and subscribe to the channel. If you hit the bell notification, you'll be notified every time I produce a new video, and I'm trying to produce as many videos as possible with lots of information in them. If you've got any questions, please leave them in the comments section below. Thank you very much.